So you're getting ready for your phlebotomy certification, and you've probably mastered the basic draw. That's fantastic. But in this explainer, we're going to level up. We're diving into the tough stuff, the complex scenarios with vascular access devices and patient complications that really show what it means to be a true professional.
Okay, let's just jump right in with a critical thinking question. This is the kind of situation you'll absolutely face, both on your exam and on the floor. It's not just about getting it right, it's about patient safety. So stick with me, and by the end you won't just know the answer, you'll understand exactly why it's the right answer.
Before we solve that puzzle, let's really ground ourselves in a core idea. Being a great phlebotomist isn't just about how you perform a perfect, easy draw. It's about how you handle the challenges, safely and professionally.
I want you to always keep two things at the front of your mind: patient safety and specimen integrity. Every single decision you make has to serve both of those goals. That's the mindset your certification exam is looking for, and it's what's going to make you a trusted healthcare professional.
All right, let's start with level 1. This is probably the most common challenge you're going to run into. Your patient has an IV line. Knowing the exact procedure here is completely non-negotiable.
Let's break this down, because every single step is a safety check. First, and this is important, you don't touch the IV. A nurse has to pause it for at least 2 minutes. That wait time is so important. It gives the IV fluid time to dissipate. Then, everything from that point on happens distal to or below the IV site. The tourniquet, the vein you choose, everything. Why? Because you absolutely cannot risk drawing the IV fluid. That discard tube, that's your final insurance policy to clear the line. And of course, you document everything to tell the full story.
And here's exactly why we have all those rules. Think about it. If you draw above an IV, you're pretty much guaranteed to get a sample that's diluted with whatever fluid is infusing. That can lead to lab results that are just plain wrong and potentially dangerous. Your careful technique is what protects the validity of that result.
Now, similar to IVs, you have catheter locks. The main risk is dilution, so you always draw a discard tube first. But here is a huge flashing red light for your exam: heparin locks. Even the tiniest bit of heparin will completely invalidate coagulation tests like a PTT or PT/INR. If a question ever asks about drawing coags from a heparin lock, the only right answer is you can't. You need to find a new site for a fresh venipuncture.
All right, these are numbers you just have to know. Exam questions love these kinds of details. It's pretty simple. 2 to 3 milliliters for your routine tests, but you need to pull a bigger 5 milliliter discard for any coagulation tests, just to be absolutely sure you've cleared out all that heparin. And it goes without saying, that discard tube is trash. Never use it for anything.
Okay, so we've covered sites that need a special procedure. Now we're moving up to level 2, the absolute no-go zones. These are sites that are completely off limits. Your job is just to recognize them and stay far away.
First on our list is the arterial line, or A-line. You'll usually find this in the wrist, in the radial artery. It's a pressurized line that nurses and respiratory therapists use for things like constant blood pressure checks and getting arterial blood samples.
So what do you do when you see one? Nothing. Absolutely nothing. Your role is just to recognize it and leave it alone. Don't ever put a tourniquet on an arm with an A-line, and definitely don't ever try to access it. It's a high-pressure line, and touching it is dangerous and way outside your scope of practice.
Next up is the AV shunt, fistula or graft. You'll see this in the arm of a patient with kidney failure. It's a surgical connection made to handle dialysis. You can usually spot it because it looks kind of bumpy or bulging, and if you gently palpate it, you can feel a very distinct vibration, which is often called a thrill. This is one of the most critical rules in all of phlebotomy. That AV shunt is that patient's lifeline. It's how they get their dialysis. If you put a tourniquet on that arm or perform a venipuncture, you could cause a clot or an infection that destroys the site. The rule is simple and it is absolute. That arm is off limits. Period.
Okay, moving on to level 3, central venous access devices, or CVADs. These are more advanced lines for very sick patients. Once again, your job isn't to access them, it's to recognize them and understand your very limited role.
You just need to be able to know what you're looking at. So CVCs often have tubes coming out of the chest area. An implanted port is a little bump you can feel right under the skin. And a PICC line is usually inserted in the upper arm. It kind of looks like a more heavy-duty IV. And here is the bottom line. You do not touch these lines. Accessing any of them requires specialized training that is way beyond a phlebotomist's scope of practice. The risk of causing a major bloodstream infection or damaging the catheter is just too high. You might be asked to help a nurse, maybe by handing them tubes, but you never access the line yourself.
Phew. Okay. We've talked a lot about complex devices. Let's switch gears and talk about things that can happen during any blood draw. Your ability to respond quickly and correctly is one of the most important safety skills you can have.
So, let's talk about fainting. What are the first clues? What should you be looking for? Recognizing the signs of pre-syncope, which is that stage right before fainting, is your best tool. If you can catch it early, you can prevent a fall and a serious injury.
Here they are. These are the classic signs you need to have burned into your memory. The patient's skin might get pale and clammy. They might tell you they feel dizzy or sick, or that their hearing is getting muffled. If you see or hear any of this, you need to act immediately. And a huge pro tip, never ever turn your back on a patient right after you finish a draw. That's the most common time for someone to faint.
This exact sequence is a huge topic for your exam. I want you to remember this order: release, remove, press, recline. Your number one priority is to get that needle out safely. So release the tourniquet, get the needle out, and apply pressure. Then you get the patient into a safe position to get blood flowing back to their brain.
You have got to know the difference between a common bruise, a hematoma, and a much more serious arterial puncture. A regular venous hematoma forms as blood leaks under the skin. An arterial puncture is different. The blood might be bright red, maybe even pulsing, and the hematoma forms really fast and is often very painful. Your response has to be faster and stronger. Stop, apply intense, direct pressure for at least 5 minutes, and call for a nurse immediately.
Okay, this slide right here is your ultimate study guide for complications. Go ahead and screenshot this for your notes. The big takeaways? If a patient says they feel a sharp electric shock type of pain, that could be a nerve, you stop immediately. If you see petechiae, those little red dots, be prepared to hold pressure for longer than usual. And for a seizure, your only job is to protect the patient from hurting themselves. Do not try to hold them down.
All right, let's bring it all together. We've gone from IVs and shunts all the way to handling sudden complications. Mastering this isn't just about memorizing facts to pass an exam. It's about building the confidence and competence to be a safe professional out on the floor.
And that brings us all the way back to our first question. IV in the left arm, shunt in the right. So what's the answer? Well, we know the right arm with the shunt is a hard no. The left arm is a possibility, but only if you follow that super strict procedure for drawing below an IV. But you know what the best answer is? The one that shows true clinical judgment? It's to stop and to communicate. Ask the nurse, is a hand-drawn option? Could we do a capillary puncture instead? True mastery isn't just knowing the rules, it's knowing how to apply them to make the safest choice for every single patient, every single time.